pleasure to introduce our next speaker, Professor Ganesh Manoharan, interventional cardiologist, Royal Victoria Hospital, Belfast, United Kingdom. Dr. Manoharan is the clinical lead for the TAVI program in Northern Ireland and function as a clinical proctor for the Medtronic CoValve and St. Jude TAVI programs. Over to you, Professor Ganesh.
Good evening, friends and colleagues. My name is Ganesh Manoharan. I'd like to take this opportunity to thank you all sincerely for this invitation. I'm sorry I can't join you all in person due to the current circumstances. I'd like to thank Anudu and his colleagues for this invitation. My task is to take you through potential complications of TAVI, and I think personally it's always better to prevent them than to try to deal with the complications, so we're going to try to spend some time doing both. So TAVI in clinical practice today is the standard of care for high-risk patients and inoperable patients with symptomatic severe aortic stenosis. The overall numbers in each our unit is increasing, and increasingly, certainly in Europe at least, moderate risk patients are offered TAVI, and the definition of moderate risk or low risk can be discussed. Certainly in Sri Lanka and in India, for example, or the Asian subcontinent, the definition of this moderate or low risk based on age can be discussed. I think a lot of this guidelines is based on Western population assessment, so we'll not go into that. Now, what are the potential complications of TAVI? I think even today, having a predictable implant depth can be challenging. I think vascular complication is probably, in terms of numerical numbers, still the largest percentage point, even if you look at all the published clinical work to date, ranging between 5 to 10%. Coronary occlusion, thankfully rare, but when it occurs, can be very catastrophic. Permanent pacemaker, still in the self-expanding area, has been around the teens. In my unit, we are achieving under 5% with various implant techniques, and that's for a discussion another day. There is, of course, stroke can be catastrophic for your patients. Annular rupture, in the vast majority of cases, these patients don't do very well, so avoiding those will be important. Then you have this other potential complication, which is infection, paravalvular leak, and ventricular perforation. So if you have annular perforation and ventricular perforation, only a surgeon can help you, and even then can be quite catastrophic. Paravalvular leak, reassuringly, with the current technologies, these events are becoming rarer. Some of the new features of the CMAR device has addressed some of these challenges. For example, the external skirt and the ability to fix your device more appropriately, and the repositionable feature of some of these devices have helped a lot of our challenges that I've spoke about. Changes in the frame conformability, being lower profile, and a more easy to use delivery system has all tried to address some of these challenges. So it's impossible for me to take you through all the potential complications. I'm going to concentrate on a few things. Vascular access complication, I think, is reasonably common, so let's talk about that. So what are the potential risk factors for vascular complication? Obviously, patient-related factors such as calcification, tortuosity, the vessel caliber, and vessel stenosis are important. There are device-related areas as well, so the type of TAVI system you use. For example, for argument's sake, let's say you take a Evolut Pro 29 or a Abbott Portico or Navitor 29 versus an Edwards Sapien 29. They are all 29 valves. They fit roughly about the same annulus, but the access requirement or the hole created, I think that's probably the right way to put it, the hole created by your delivery system when you advance a Sapien 29 valve is at least 3 millimeters bigger than the hole created when you advance an Evolut Pro device sheathless or an Abbott Navitor device sheathless. So the OD of the capsule of the Navitor device or the Medtronic device is something like 6.1 to 6.2 millimeters, whereas a Sapien device cannot be advanced sheathless, so you have to advance it through the expandable sheath. The OD of the expandable sheath is almost 9.4, 9.8 millimeters. So you can see that the type of device you use impacts on the outcome. And then finally, operator-related complications. I think this is something that we can address, we can look at. I think if you're too aggressive when you're trying to push, be always be able to understand how much resistance you get. So for some reason, when people do TAVI, they kind of forget the learnings and the teachings that our mentors have given us when we're doing coronary intervention. So when you push too hard, you always cause problems. When you pull too hard, you always cause problems. If you leave things in your vessel for too long, it will always cause thrombosis. So remember all that, I would say basic but really important teachings of coronary intervention in the TAVI era. So first thing is you have to respect calcification. You can see that the sheath had some difficulty advancing. The operator tried to push a little bit and there was a sudden give. So they thought, okay, let's just stop there. We can't go any further. And usually at this point, you can still advance your delivery system, perform the procedure. The hemodynamics were normal. There was no evidence of leak anywhere. So the operator started continuing the procedure. But whenever our advice is always look at the heart when advancing something. So the wire was in the LV cavity and we were observing the heart, and the operator kept pushing the balloon and the balloon never reached the heart. So naturally you go back down again, and this is what we found. You can see that there's a loop suddenly appeared in the pelvic cavity floor. So the wire was naturally pulled back, and this is what you see. There's an absolute massive rupture of the iliac artery. Now, reassuringly, now you can see that there is a balloon already in the iliac lower femoral. So that's an important piece of advice. Always have a balloon available somewhere in your room. If you're not going to do pre-dilatation, just keep it somewhere in the room. Usually, I think, if you have a ASD sizing balloon, it's a very soft balloon, but it'll go up to whatever diameter you want to even include the lower abdominal aorta. So I have a sizing balloon, ASD sizing balloon in the room that will allow you to occlude the aorta. But in this case, we were able to the operator was able to safely pull the balloon back into the iliac and occlude the iliac. That bought the individual some time. So once you've stabilized it, this patient then actually went for surgery. Today I guess I probably will try and put a covered stent in, but there's always be challenging when you see so much calcification to cover it safely. Because the artery was occluded, the anatomy was controlled. This patient actually went for surgery to fix the iliac artery, and they came back 4 weeks later for TAVI transfemoral as well, which is I thought was quite brave for the patient. But anyway, that's the only option she had. So how do you deal with perforation? There are many ways of dealing with it. This is after the procedure is performed, large sheath is removed, and you can see that's a antegrade access from the right to the left catheter. Angiogram was performed. You can see a clear perforation, usually due to a tear on the artery. Though the sutures have gone in, there's still a leak. These are relatively simple to deal with if you have the technology in your room. So in my unit, for example, we have a box called vascular complication kits, and it has in it covered stents, balloons, sheets, and various other technology. So the balloon was first advanced from the other side to occlude the vessel. We can then localize this balloon to identify exactly where the hole is. And then after that, you can consider either stent versus surgery. In this case, a balloon expandable stent was used, and you get a clean outcome. So one of the key things you have to do in all of these patients, of course, look at your CT very well and understand exactly what the diameter of the vessel is in the rare circumstance where you do need to put a covered stent in the area. So take home message of vascular complication, the vast majority are due to technical operator related, in my view. Vascular complication impacts on acute and late outcome during TAVI. So the attention to detail is very, very important. If you recognize the complication, then you can diagnose it safely. So it's important, for example, I showed there where you do have the ability to assess your vascular access immediately after closure, because you can find these leaks and you will not notice it very well if you don't take an angiogram, especially in the very large patients. You can lose almost 2 liters of blood and not knowing that blood is gone. In the room, it's important to have the occlusion balloons, the covered stents, and also have access to surgeons who are friendly. They don't need to be in the room, but you need to be able to access them. Vascular surgical access is important. And then, I guess for me, one of the key areas that we do need to look at is for how to define complications in the VARC2 and VARC3 has enabled us to do that safely. So stroke is catastrophic when it occurs. I'm just going to take you through a case, and then we can talk about how to deal with it. So it's an 82-year-old female who presented in 2010 with single episode syncope and shortness of breath. She had previous history of an Hancock size 23 valve implanted in 1994. She has a previous history of TIA, but otherwise is very independent. So prosthetic valves, a biprosthetic valve that's failed, can be very, very friable. Just remember that. So quite critical aortic stenosis, overall risk was prohibitive for redo surgery, certainly for her age. So TAVI for valve-in-valve was given as an option. And you can see the access is quite hostile. So we decided to take this before the Pro Plus came in line. We decided to use a 26 COVAF prosthesis. Position, now this device is not resheathable at this version. You can see that the valve evulsed during deployment. Reassuringly, nowadays you are able to resheath and go back in again. And that's what we did. We took the whole thing out and took a new device back in again. In those days when you can't resheath, and it's important to share with you what happens when you use a non-resheathable TAVI technology, which I think is still available in some Asian countries from Asian manufacturers. I think resheathability is for me at least, has significantly changed how we do TAVI today. It gives you an added sense of reassurance. But, for cost purposes, you may opt to use a non-resheathable self-experiment device, and that's the only way you're going to be able to retrieve the device through the sheath, pulling it across the arch into your sheath. And we reloaded, deployed the valve, and patient was well, went home. Thankfully, no evidence of stroke. But what we found was that when we took the first device out and washed it on the bowl to reload it, this is what we found in the bowl. I mean, you don't need a microscope to see this. It is quite a large chunk of pieces of debris. And you can see that there's also a bit of tissue there. This was sent to histopathology, and they confirmed that these were calcific bits and pieces from the old bioprosthetic valve. And the reason to show this, I think, is when you're doing a valve-in-valve procedure or even a native TAVI procedure, there is always that risk of embolization from the native or the old bioprosthetic tissue. And increasingly, certainly in Europe, operators are using carotid filter devices. In my unit, we don't do it routinely, but I think we have a very patient where there's a high risk of embolization, such as mobile tissues on the tip of the leaflets. Then to consider embolic protection will certainly reduce the risk of strokes. But I think resheathability has enabled us to deal with this complication in a much more controlled and safer manner. So TAVI does carry risk of periprocedure stroke and other embolic phenomena, especially I think they're using to treat failed bioprosthesis. Remember, failed bioprostheses are very friable. So in my unit, at least in my hands, I do not predilate these valves. You go in without predilation to minimize the risk of tissue friability and fractures. I think embolic protection device could improve outcomes. There's a large randomized trial going on in Europe at the moment, looking at clinical stroke, not just MRI stroke. And personally, I think the resheathable, repositionable devices that are currently available, and there are two devices available, one from Medtronic, one from Abbott, certainly I think has improved this risk significantly. So I'm going to finish off by showing one case that addresses other challenges of TAVI. This is an old case, but I think it's really, really relevant even for today. It's an 87-year-old male who's large, who has severe aortic stenosis and symptomatic, previous pacemaker, atrial fibrillation, and a echo showed, which I hope to show, quite severe aortic stenosis, the severe left ventricular hypertrophy, but with good function. The TOE. Now this is before the time, you can see the date that this is before the era of CT. So this again amplifies the importance of cardiac-gated CT, good quality cardiac-gated CT in TAVI era today. Coronary angiograms show these features, both access appeared acceptable. So At that time, we decided to do a PCI to the RCA and the LAD, and then TAVI was performed 2 weeks later with a Medtronic Cobalt 29 valve. Now, this was a non-resheathable valve. You can see how hypertrophied the left ventricle is, how small the cavity is, despite this man being almost 6 feet tall. So when you see something like this, you need to be aware that the ability for this heart to deal with hemodynamic compromise during TAVI, either if you have acute paravalvular leak, acute aortic regurgitation during pre-dilatation, or severe MR, these patients will not tolerate hemodynamic compromises very well, and they'll spiral down very, very quickly. And giving adrenaline for this patient is an absolute no, because you will cause what we consider a suicide ventricle. So you can give phenylephrine, but adrenaline is not a drug to give. So we went here with TAVI. You can see that cardiac output is very low. There's still slow flow of the aorta. Pre-dilatation performed. Now, in those days, pre-dilatation, again, another important point, was done in a valve size to balloon size. So if you take a 29 valve, you take a 28 balloon. So recommendation nowadays is for pre-dilatation, please take the minimum diameter of the annulus for pre-dilatation. For example, you're going to take a 29 valve, but the minimum diameter is 20. Do not take any balloon bigger than 20. So you can take an 18 balloon to pre-dilate or 20 balloon to pre-dilate. Anything bigger, you potentially can cause problems. So pre-dilation was performed, then there's a sudden drop in blood pressure. Patient became very unwell and quite intimate in CPR. The transthoracic echo showed no effusion, so that's the first thing you need to exclude. There was no left ventricular perforation, so there's no pericardial effusion. Angio showed severe aortic regurgitation. You can see that there's a free-flowing regurgitation of the aorta, of the aortic valve. Anyway, we went very quickly to deploy the valve. As the valve was being deployed, the AR, of course, improves, and you can see that the hemodynamics started to improve. On the left-hand panel, you can see that 2/3 really the valve is clearly too deep. So resheathability was not available those days, so you gently track the valve back by pulling gently, and you can see the valve position is getting better. Hemodynamics improved. Patient, by the way, at the moment is still not intubated, still conscious. We release, and then this happens. Now, this can happen even today. If you do not confirm that for self-expanding valve, that your anchors are fully released and you think you can pull it back, if one is released and the other is not released, it's really, really easy to avulse your valve. So be very careful. So during deployment at 2/3, just before final release, check your position is good. Upon final release, make sure you can visually confirm that all your anchors are fully released. First point. Now, once this has happened, the patient became quite unwell again because of severe AR, CPR was commenced. The thing we did then was to pull the super stiff wire out of the annulus, and the blood pressure improved. And what this happens, so it's something to remember, you only position your super stiff wire across your native annulus once your valve is ready and loaded to go. I've seen some centers where they cross the valve and immediately put a stiff wire in the left ventricle, and then the valve gets started loading. It takes about 10 to 15 minutes sometimes to load these valves. So when you have a stiff wire across your native annulus, you're already inducing aortic regurgitation. You also then have a stiff wire in the left ventricle can cause perforation. A wire left anywhere doing nothing can cause thrombus, can cause stroke. So remember then, once you cross the valve, you wait. You do not put a stiff wire across the LV, in the LV until the valve is ready to go. But pulling the stiff wire out, in this case, now the BP improved, we had time. So these are the measurements. The patient was feeling better. There was still a peak-to-peak gradient across the valve of 5 mm of mercury, so a significant improvement gradient. But the patient had still moderate to severe aortic regurgitation, and we felt that we probably should put a second valve in to improve at least the leak. So we went ahead, loaded the second valve, and we went ahead to do the procedure. The minute we crossed the valve again with the stiff wire, the blood pressure crashed and the patient became hemodynamically unstable. Now you see what's happened now. When we were advancing the second valve through the first valve, it pulled the first valve with it into just below the STJ. Now by this stage, this patient was getting intermittent CPR. You can see the cardiac output is really spiraled down. Time was not on our side. So we went ahead, and you can see that this is not slow motion. This is the heart really not responding very well to the severe AR. And we released the valve, and we started doing CPR. Now, if I was there, I'll wait to ask some questions, but I think you can see a couple of important structures of the heart that's not filling very well. You can see that the left main is blocked and the right coronary artery is blocked. And this has happened because of us dragging the first valve into and crossing the STJ, deploying the second valve, and now what you have is almost a perfect conduit between the LVOT and the aorta, blocking the coronary arteries completely. So no coronary perfusion, CPR ongoing. So the only way we can now save this patient was to snare and pull the old valve out. And this is what happens when you put a first valve within a second valve. You position the first valve into the second valve and you extend the first valve's leaflets to become a tube. So both valves are pulled out of size, blood pressure hemodynamically improved, coronaries perfused, we stopped. So the message then is, I'm going to skip this part. The patient was fine at the 1 year follow-up. The key point now for us to remember is one, be prepared for the unexpected. Do a checklist of your cath lab in detail to make sure all the backup equipment is available. Undersize the balloon for pre-dilatation. I've already went through that. Remove the stiff wire if you find a significant drop in blood pressure and you have to load a second valve. Consider that. And this is the most important thing. If you have, for whatever reason, deploy the first valve and it's evulsed out, snare the first valve, pull it into the ascending aorta, keep it snared, go across the first valve to the second valve while the first valve is still snared in the ascending aorta or just at the arch. Position your second valve into the annulus, then release the first valve. Then you can take the snare out, take a pigtail in, and then you can use the second valve, deploy as normal. So I'm going to skip these. So in summary then, technological advances are impacting positively on TAVI outcome. Improving outcomes are also due to better patient selection and operator experience. I think we do still require further improvements in technology to make this procedure safe and predictable. It's really, really important to look at the CT before, procedure during, and manage the patient post. And with that, I will stop. Thank you all for your time, and I hope you have a successful meeting. Thank you for listening to me.
Thank you, Professor Manoharan, for that comprehensive lecture. I'd like to know whether, Professor Manoharan, are you online with us? Are you there? No. Yeah, I'm sorry, because he has just told us a little while ago that he's unable to join due to connectivity issues. Anyway, the symposium is open for discussion. I believe Dr. Giza Fontas is with us, and he will take any questions that you have to ask.
Is Giza online? Hello, Giza.
Hi, I can clearly hear you.
You can hear us? Okay. Can I ask a question, Giza? I saw the guidelines are still, the implantations are above 75-year-olds. Are you still in Europe sticking to the 75 and above? The age?
It's a difficult question in Hungary because of financial issues. So we, in the last 12 months, we implanted more than 300 valves. So now the numbers are really high, but still all our patients are either at high risk for surgery or the threshold in our hospital is still 80 years for offering the patients TAVI, regardless of comorbidities and frailty. So we still are at 80, but I guess that after doing 300 per year, probably we will have shorter waiting lists, and we can go down to the 75-year-old age limit, which was suggested by the new guideline. Cannot hear you. Do you hear me?
We hear you clearly, yes. Can you hear us?
Now I can, yeah. I can hear you now.
Yes, sir. Just about the age in patients who will have probable patient-prosthetic mismatch. Does the age still stand at 75, or is it any different?
75 now, but based on the guideline, is a general rule. Of course, there are patients where the heart team makes a decision to do TAVI even in a much younger age. It can be the patient prosthesis, the danger of patient prosthesis mismatch. It can be because of comorbidities, previous cardiac surgery, porcelain aorta, or any other reason. So it can be below 75. But the guideline says that if the patient has no comorbidities above 75, we should go for TAVR, or we should preferably go for TAVR.
Gisa, what about the presence of aortic regurgitation? Is it still a contraindication? A mild aortic?
Yeah. Having aortic regurgitation combined with aortic stenosis is not a contraindication. Still, for most of the valves, the pure aortic regurgitation is an off-label procedure. There is one exception, which is the Jena valve from Germany. They have a CE mark approval for pure aortic regurg indication because this is the valve that has 3 legs that can be positioned inside of the 3 sinuses. So the stability and fixation of the valve is very good even in pure aortic regurg patients. With all the other available transcatheter aortic valves, the pure aortic regurg is an off-label procedure. We sometimes do it if the patient is at high risk for surgery, but keeping it in position is usually more difficult. First, because of the aortic regurg. Second, that in most of these cases we have no calcium, so the annulus is more a dynamic structure and it's a bit slippery, so it can be very difficult to keep it in position. But to go back to your question, if a patient has a significant aortic stenosis plus aortic regurg as well, then the indication is okay for doing the procedure.
Just one question. What about the patient with pre-existing right bundle branch block? Do you put a pacemaker in advance, or is it high risk of getting a complete heart block after the procedure?
Yeah, clearly this is the patient population who are at high risk for having a complete AV block after procedure, but it's not a rule. So we never put a pacemaker as a prevention before TAVI procedure, but clearly in this patient population, having a pacemaker need after procedure is very high. So in this patient population, especially if we see that the QRS becomes even wider, then we keep the patients not only for 1 day, but 2 or 3 days on a temporary wire and on the telemetry or ICU.
Thank you very much. One more question. In Sri Lanka now, we are shifting more towards warfarin-free surgeries. I have seen couple of patients been getting, aortic valve replaced with pericardium, which is called Osaki procedure. So if they get restenosis in the later of life, is it possible to go ahead with? Have you any experience of this patient getting TAVI later on in their life?
You mean after Osaki procedure?
Yeah, Osaki. I don't know. Because it's new procedure for us. I don't know whether you have any experience getting restenosis, because it's like a native valve. In that case, probably we could consider TAVI in the future if they get restenosed. Unlike getting a prosthetic valve, in that case we cannot do anything if they get restenosed.
I think if restenosis, it will behave technically for the TAVI procedure perspective like a stentless biological valve. Of course, we need to have a good CT measurement calibration before to see what are the structures that will be able to anchor the valve in place. Of course, we need to check very carefully how the sinuses are and what is the height of the coronary after the Osaki procedure. But I think from the technical point of view, it looks like a biological valve. But to be honest, I have no experience doing TAVI after Osaki procedure. And I don't remember any publication on that subject as well.
There was one more question. Regarding the aortic valve measurements, now we are doing CTs. Now the rise of the 3D echo. What is your view on using 3D echo for measurements of aortic root for TAVI?
Yeah, I think the echo is improving extremely fast, but still the gold standard is the good quality CT scan, ECG-gated good quality cardiac CT. Either with the very best Philips Epic CVXI, you cannot get the same reproducible data. It might happen that we arrive to that in a couple of years, but still, even if a patient has chronic kidney disease, we always do the CT. We truly believe that this is the most accurate way of sizing the patient prior to procedure.
Excuse me. Dr. Gisa, I know that you are mostly experienced in Evoluta. Have you got any experience in using MyValve, which is balloon expandable?
Yes, we have the MyValve available. I'm also proctor for MyValve, mostly in Europe. So we have experience with that. And I think it's a good valve. So when we started to do MyValve was that there were patients who were not suitable for Evolut, or not suitable for Portico and Accurate Now, which we also have in my cath lab. So these were the patients who needed to treat transapically, the patients with mitral bioprosthesis problem, and also if a patient has annulus size larger than 30 millimeters, then we can still treat those patients with the biggest MyValve. And we cannot treat with any of the others. So this is how we started like 2 years ago, 1.5 years ago, the MyValves. And to be very honest to you, it's a good valve, easy to handle, and it works well. We didn't have any serious complication.
Using for larger annulus, and what I mean is, are you using it for selectively for larger annulus or approach from the transapical? You're selectively using it?
Yes, for Evolut, the biggest size we can use is 30 millimeter annulus size for the tricuspid. For the Accurate Now, it's even smaller a bit. With the Portico, it's even smaller. And in Hungary, we have a lot of large patients with large anatomies. And we had at least 10 patients who we could treat with a MyValve with some extra saline loaded in up till the 34 millimeter annulus size. It can happen theoretically that if you implant it to a 34 millimeter native annulus, you will lose the ability of full coaptation of the valve, and you're going to have a central leakage. In this case, we are prepared to implant the second MyValve inside of the first one to solve this problem. But it's just a theory. It never happened to us that because of this reason, we had to implant the second valve.
Okay. Thank you very much. I think time.
Thank you very much, Dr. Fontas, for your excellent presentation as well as answering all our questions. Thank you very much. And I'd like to thank you. And I'd like to thank Dr. Fontas as well as Dr. Ganesh Manoharan for his excellent presentation. In sake of time, we are closing this session.